Good morning, everybody. Today I'm going to speak about the pseudophakic retinal detachment and its management. If we look to retinal detachment in pseudophakia, they are more extensive with macular involvement, and usually they are complicated by PVR very easily. The tears responsible for pseudophakic retinal detachment are usually small and flap tears at the area of the vitreous base. Many studies had shown that pars plana vitrectomy is superior to scleral buckling in eyes with pseudophakic retinal detachment. However, media opacity and peripheral capsular opacification, which is common in pseudophakia, can interfere with the observation of the breaks, which is the primary essential point to treat the pseudophakic retinal detachment. And as you can see, this is classic pseudophakic retinal detachment with a very peripheral retinal break. Rheumatogenic retinal detachment after sutural small incision cataract is still a problem faced by ophthalmologists. The management include either scleral buckling, pneumatic retinopexy, or vitrectomy. And I will show you some examples of cases which were managed by different techniques. This is a case of supratemporal pseudophakic retinal detachment, and this case was managed by a buckle. Since there was no pathology in the anterior segment, no complication from the pseudophakia, then this was managed by just a buckle. And as you can see, there is a small flap tear in the upper temporal region and upper temporal retinal detachment. Cryo was applied to the break till you get complete whitening of the break, then screening of the rest of the retina, placement of circumferential buckle, and drainage of the subretinal fluid, and now the retina is flat on the buckle. And this is the post-operative appearance 1 week following surgery with the gas is still inside the vitreous cavity, and the post-operative appearance 1 month following the buckling procedure with flat retina. Another case with supratemporal retinal detachment. Again, indentation, a flap tear, as you see, is present at 12 o'clock, to which cryo was applied, screening of the rest of the retina, because as you know all, there are usually more than one break in the retinal detachment. So if you find even the main break, you have to look for other breaks in different quadrants. And this is the post-operative appearance of the patient with the gas bubble still in the vitreous cavity. Another problem which is present in pseudophakic retinal detachment is the presence of inferior break. Although the vitrectomy is very tempting for the surgeon to do vitrectomy, but the problem with inferior retinal break is that you don't find any support for tamponade with either the silicone or the gas. Upper tears are usually supported. So the buckle is a good idea even if the patient is pseudophakic. And again, same procedure, cryo to the break in the infratemporal region, screening of the rest of the retina, placement of the buckle, drainage of the subretinal fluid, and if you have a soft eye following the drainage, you may inject air inside the vitreous cavity or gas. And this is the post-operative appearance with the buckle in place and the retina reattached. Again, another infratemporal single break, which was managed just by a radial sponge to the infratemporal area and the post-operative appearance with the flat retina. The advantages of performing vitrectomy to repair a pseudophakic retinal detachment over a scleral buckle or pneumatic retinopexy, a high single surgery anatomic success rate, removal of all traction on the retinal tears, removal of the vitreous cells or hemorrhage, increased visualization of the peripheral retinal pathology, and the ability to perform a posterior capsulectomy or capsulotomy if it's hindering the visualization and finding of the retinal break. As you had seen, usually the breaks are very small, are flap tears, and you have to search for all the break, otherwise you are going to get a failed surgery following treatment of pseudophakic retinal detachment. Again, if you have any wrinkling on the surface of the retina or any element of PVR, you have to go for vitrectomy, and you have to clear all the vitreous cells. And if you are going to go for vitrectomy, you have to remove all the posterior hyaloid. So staining of the posterior hyaloid with Kenacort, which is a low visual aid for us to see the posterior hyaloid, can help to remove the whole vitreous. Air fluid exchange, laser to the peripheral breaks, and maybe application of more laser to 360 degree if you are not aware of the pathology in all quadrants. And then air silicone exchange. Again, if you have an opacified posterior capsule, you have to go for vitrectomy. You can't do it by buccal, because as you can see in this case, the posterior capsule is opacified on the temporal region, and when we gone posteriorly to treat the retinal detachment, the break was present in the same quadrant as opacified posterior capsule. You will never be able to see this break if you are going for scleral buckling. Another alternative in treatment of pseudophakic retinal detachment is not using perfluorocarbon or posterior drainage retinotomy, but draining the fluid through a peripheral break, just by tilting the globe during the surgery and putting a high vacuum instrument like the vitreous cutter on the vacuum mode till you get complete flattening of the retina. Then you apply your laser to the break through which you had drained the subretinal fluid, and apply to the laser and apply the laser to other breaks present in the retina, although not related to the configuration of the pseudophakic retinal detachment. But by the way, there may be some breaks in a flat retina, but you have to treat it since you are inside the eye. Video شغال. لا اللي وراه عاوز اجريه بس. As you can see, we drain through the peripheral break without the need for a posterior retinotomy or injection of perfluorocarbon, just by tilting the globe during the surgery. There are some complications of treatment of pseudophakic retinal detachment, including macular hemorrhage during the drainage of the subretinal fluid. Some cases are very mild, so that you can leave it for spontaneous absorption, although replaced by mottled retinal pigment epithelium. Again, intrusion of a suture inside the vitreous cavity if you are buckling pseudophakic retinal detachment. As you can see, the ethipond is seen inside the vitreous cavity. A very high buckle which induces myopia. Recurrence of the detachment with PVR, and you have to interfere with ray vitrectomy and silicone oil injection, or retinal incarceration during the drainage of the subretinal fluid. And as you can see on the nasal side, there is a retinal fold which corresponds to the area of the incarceration, and you can modify that by just adjusting the buccal to support the area of the incarceration. In a study had shown that there is no significant difference was observed between scleral buckling and vitrectomy as regard the primary and final anatomical and visual success rate. New vitrectomy machines with high cutting rate and low vacuum allowed the surgeons to remove the vitreous safely from the mobile retina. Adjunctive drugs such as triamcinolone adhered and identified residual cortex, which is very important for us to visualize the residual cortex, and the fine microsurgical instruments had allowed us to treat retinal pathological features. Scleral buckling is still a good option for treatment of pseudophakic retinal detachment with or without PVR grade A. And thank you for your attention.